Good evening. Welcome to the IC on UVA of Drishti 2022. We have eminent speakers here from all over Kerala, and we have Dr. Anuradha VK from Arvindai Hospital, Coimbatore. I will move on to the scientific program. First talk is by Dr. Rajeshri Nambiar from Little Flower Hospital, Angamali. Her talk is on anterior uveitis.
Good afternoon, all. As we begin with our session on uveitis, I shall be talking on approach to anterior uveitis. History taking and clinical examination remains the backbone of uveitis. This is followed by pattern recognition, looking for the possible etiological diagnosis, getting the relevant lab investigations done, and in non-responsive cases, we advise extensive investigations followed by treatment. Now, as we begin, let us go through the classification of anterior uveitis. It's classified based on the course as acute, recurrent, and chronic, based on the etiology as infectious and autoimmune, based on the pathology, it's granulomatous versus non-granulomatous uveitis. Now, coming to a few differences between acute and chronic uveitis. Acute is sudden onset, associated with pain, redness, photophobia. They may be self-limiting. They will have circumcorneal congestion, and IOP may be low. Whereas in chronic, it is insidious in onset, may be symptomatic. The patients could complain of floaters and decreased vision. There may be little congestion, and the IOP may be high. Now, based on the clinical stages, let us go to the few causes of uveitis. Acute single episode, the common causes are trauma and a reaction to any infection. Acute recurrent, you have your HLA-B27 related uveitis, viral, and the Posner-Schwarzman. Coming to causes of chronic recurrent uveitis, you have your viral, tubercular, sarcoid, Fuchs, GIA, and your retained intraocular foreign body. Now, differences between granulomatous and non-granulomatous uveitis. The non-granulomatous uveitis is seen in, it's usually an acute and a short duration with more of exudation, small KPs, Copies nodules, could be seen in HLA-B27, herpes, and Fuchs. Whereas the granulomatous, it's usually chronic, insidious. There are large mutton fat KPs. You could have Bucsaca's nodules and dense posterior synechiae. This is seen in TB, VKH, herpes, and sarcoidosis. Now let us go through a few cases. This was a 15-year-old boy who presented to us with a history of trauma. He had pain, redness, and decreased vision. If you see, there is significant amount of congestion with a large, with AC reaction, few KPs. So this, what we are dealing with, is a case of acute onset of non-granulomatous uveitis following trauma. There are no investigations required. This patient was started on topical steroids and cycloplegics. He came back to us after 3 days. He had gone to school and stopped all his medications. Now, you have an eye which has got a few fibrinous membranes and a little about membranes in the anterior chamber. This patient was then admitted, started on oral and topical steroids, and he's doing well. Now, this is a lady, 46-year-old female, who presented with pain, redness, and photophobia of 1 week duration. She gave us a very important history of morning stiffness and back pain. On presentation, she had significant congestion with small fine KPs and a fibrinous membrane in the pupillary area with a 3 mm hypopyon. What are we dealing with? This is a case of acute non-granulomatous anterior uveitis associated with back pain and morning stiffness. This is mostly HLA-B27 related uveitis, usually seen in 30 to 40 years of age, unilateral. Other eye may be involved later, and they are associated with hypopyon and fibrinous exudation. These are some of the other causes of HLA-B27 related uveitis, and history taking is very important so as to make the diagnosis. Now, the take home is, how do we treat this HLA-B27 uveitis? Aggressive topical steroids 1 hourly with cycloplegics to break the synechiae, and systemic corticosteroids in case your topical treatment is ineffective. As there might be a need for a longer period of high-dose steroids, immunosuppressants are added. Now coming to your differentials in hypopyon anterior uveitis, it's immune-mediated HLA-B27 and Behçet's, infectious in endophthalmitis, and you have your masquerades. Now what are the differences? In HLA-B27, you have a hypopyon, which usually does not move very freely, with the history, which is very important. In Behçet's, you have a shifting hypopyon. In endophthalmitis, the history is very important, looking for history of any fever. If it is post-cataract surgery, look for any infiltrate at the section. And in neoplastic, usually what we get is a white hypopyon, and these, they usually do not respond to steroids. Now this is a 53-year-old female who presented to us with pain and redness in the right eye since 3 months with photophobia. On examination, her vision was 624. She had diffuse corneal edema with large metaphate KPs and cells with areas of patchy iris atrophy, and her intraocular pressure was 34. So here we are dealing with a case of herpetic viral anterior uveitis. Why? It's unilateral, pigmented KPs inferiorly, areas of sectoral or diffuse atrophy. You could have a dilated pupil, decreased corneal sensation, dendritic scar, and the IOP is high, usually due to viral trabeculitis. Now these are the other viral uveitis in which we have your HSV. In HS, it's HZV. HZV, we have to ask the history of zoster dermatitis. And in CMV, as compared to the other two, the AC reaction is relatively less, and there are no posterior synechiae, and the IOP is more than 50 millimeters. Now this is another lady who presented with a hypopyon with a little amount of blood-streaked hypopyon. So this was a case of HSV viral uveitis. Now what is the treatment of herpetic viral uveitis? Basically it's oral antivirals. We have your acyclovir 400 milligrams 5 times per day along with your cycloplagics and topical steroids, and you have to also treat the intraocular pressures. So what are the other causes of hypertensive uveitis? Other than your viral, you have your Fuchs, Poschner-Schwarzman, etc. IOP may be low in HLA-B27 and NADI. Now this is a 47-year-old male who had no history of any redness, but he came to us with diminution of vision. He had stellate fine KPs with a posterior subcapsular cataract. There were no posterior synechiae. He had associated vitritis. So this is a case of Fuchs heterochromic iridocyclitis. The significant features are it's usually unilateral, and the patient presents with decreased vision usually due to cataract. There are no posterior synechiae. There could be cells in the vitreous, and usually the inflammation does not require treatment. Now this is a 54-year-old female with pain, redness, and photophobia for over 6 months. She was on steroids, had recurrences on tapering them. Now if you see, there are large mutton fat KPs with Musaka's nodules, significant AC reaction. We are dealing with chronic granulomatous anterior uveitis. And what are the differentials? Look for tuberculosis, sarcoid, syphilis, etc. And here, history taking is very important, followed by investigations to finish the diagnosis. Now the investigations normally done are your CBC, your chest X-ray, Mantoux, quantiferon, HRCT for TB and sarcoid, then your syphilis and evaluation, ACTAP in case of herpes. This is a 58-year-old male who presented with history of trauma. What we see are some atypical nodules along with a blood stain. And since this was an atypical case, an HRCT was done, and he turned out to be a case of adenocarcinoma of the lungs. So finally, if diagnosed and treated on time, we can treat uveitis without long-term sequelae. And regarding the use of steroids, they usually, in patients in whom anterior uveitis is not responding to topical drugs, you can start them on oral steroids, and you have to give them use enough, soon enough, long enough to get the desired results, and you have to start at a high dose and then taper slowly. Thank you so much.
Thank you, Rajeshri. Dr. Anuradha, for your comments.
Any questions from the audience? So, anterior uveitis is probably the most commonest variant of uveitis you will see. And some of the common mistakes we make is, treating all anterior uveitis the same. For example, whether you have a HLA-B27 associated uveitis or JIA associated uveitis, it's not to be treated the same way as a idiopathic anterior uveitis. Secondly, it's not like one treatment fits all patients. It's not like 6 times spread for all patients. You have to tailor it according to severity of inflammation. The other thing which we commonly see is excessive use of steroid antibiotic, which I really don't think is required in uncomplicated uveitis. If there is no epithelial defect, there's no indication for using a antibiotic here. You can use pure steroids, it doesn't do any harm. Any comments?
Okay, next I invite Dr. Vandana Pradeep for her talk on intermediate uveitis.
Okay. Very good evening. So, uveitis has always been the most challenging diagnosis in ophthalmology. This is me seeing a case of uveitis around 5 years back. Never actually, nothing actually made much sense to me. They used to talk about TB on one hand, they used to talk about autoimmunity on the other hand, and about sarcoidosis, and then about worms, and even about tumors. So uveitis was like that. Fast forward to now. Now when I see a case of uveitis, my face goes like this. Okay, so there you are, your uveitis. And my mind, this runs through my mind. Translating a very popular Malayalam dialogue, like, whereupon I shall tell thee who thou art and who I am. There's this thing about uveitis. Once you get into uveitis, once you actually get the hang of uveitis, you get into this detective mode. You know there's a culprit somewhere out there. And there's this constant challenging voice on the back of your head every time you see a case. And it goes like, I don't know who you are, but I will find you and I am going to kill you. So I think that works better I think the joke works more with uvea doctors. So anyways, a very warm good evening. I'm Dr. Vandana Pradeep, and I'm here to talk about intermediate uveitis. This is going to be a very straightforward presentation. I'm going to deal with just the basics. So intermediate uveitis, the first thing to be understood is that it is an anatomical diagnosis. It is not a clinico-pathological entity. It only means that the inflammation is localized in the vitreous and the peripheral retina. The Sun classification classifies intermediate uveitis into pars planitis, posterior cyclitis, and hyalitis. First described by Fuchs in 1908. Since then, various terms have popped up: peripheral uveitis, chronic posterior cyclitis, peripheral uveo-retinitis, pars planitis, cyclochorioretinitis, and chronic cyclitis. They all basically mean one and the same thing. So, IU is usually a chronic relapsing condition, accounting to up to 25 cases in cases of uveitis. Most common in the third and fourth decade of life, and it can account to around 20% of the pediatric cases. Etiology, idiopathic is the most common, accounting to around 70% of cases of IU. Any intermediate uveitis without any systemic associations along with snowballs and or snow banking is known as pars planitis. Secondly, it may be infectious. It may be associated with TB, leprosy, syphilis, Lyme disease. It may be non-infectious, where it is associated with sarcoidosis, MS, inflammatory bowel disease, Sjogren syndrome. So usually it's of insidious onset. It is usually bilateral. It may be asymmetrical. Patients usually have a white eye. There are no complaints of pain, no photophobia, no redness. So as I said, the inflammation is localized in the vitreous or the peripheral retina. So the most characteristic feature is the presence of vitreous cells. Presence of vitreous cells and vitreous condensations results in the patients having complaints of floaters. These may aggregate and usually in the inferior periphery, and that is known as snowballs. Snowballs may further accumulate, and that is known as snow banking. And the vitreous inflammation may be of various intensities. It may be dense enough to even hinder the view of the retina, and that may result in blurred vision. So this is how vitreous cells look. Vitreous cells may be of various degrees. This is how snowballs look, and this is snow banking. Most commonly in the inferior periphery may go up to 360 degrees. This is vitritis in various intensities. So nothing in uveitis is exclusive. So you can have associated anterior uveitis where there may be associated KPs, there may be AC cells, there may be posterior synechiae. You can have peripheral retinal vascular changes, inflammatory changes in the retina, and disc edema. So usually intermediate uveitis is a benign condition. The complications arise due to the chronicity. Complications most commonly chronic CME, glaucoma, cataract, optic atrophy, and retinal detachment. These are all causes of defective vision in intermediate uveitis, most commonly chronic CME. So diagnosis, as I just said, the diagnosis of intermediate uveitis is purely clinical. Investigations are done to look out for any underlying condition. So remember that guy? So whenever you see an case of intermediate uveitis, take out your detective hats and get a detailed history. Always do investigations and look for any signs of infections. Look for TB, look for sarcoidosis, get a chest x-ray, or if needed a CT chest. So these are all aimed at looking for any underlying associated systemic conditions. So the rule of the thumb is rule out infections and rule out malignancy. Once you do that, you can do other investigations like OCT. This will help you assess the status of the macula, whether you have any CME, whether you have any retinal stippling. B-scan ultrasonography is done in case of an opaque media due to vitritis you want to know the status of the retina. And FFA if you want to pick up any subclinical vasculitis. So once you're done with that, treatment. So treatment, the main thing is treat the cause, if any. The next step is our step-ladder approach to uveitis, where, as usual, corticosteroids are the mainstay in treatment. If it is not responding to corticosteroids, you go ahead with immunosuppressants, biologicals, and surgery. The main reason for doing surgery is, one is you want to decrease the inflammatory load, and secondly, you want to clear the media. So that is the end of my presentation, covering the basics of intermediate uveitis. I hope it has been helpful. So I think I'll hand over the mic to Anuradha ma'am and for her comments.
Any questions from the audience? Thank you, Vandana. I think, when you look at the anatomical classification of uveitis, probably intermediate uveitis is the one which gives you the least clues as to etiological diagnosis by, just looking at the. So it's very important that you pay attention to the history, and also, you'll have to rely on the test. Now, from my experience, some of the things which can look like intermediate uveitis is old vitreous hemorrhage, okay? People have treated it as intermediate uveitis. The intraocular lymphoma. The intraocular lymphoma, you should suspect when you have somebody who's in the older age group, 50, 60 plus patient presenting with intermediate uveitis. They typically have this peripheral sheet-like cells, and they can also have, classically they have the sub-RPE deposit, which can look like drusen on OCT. The third one is the amyloidosis. Okay, so doing a vitreous biopsy and subjecting it to pathological tests can be helpful. And not to miss out, delayed or chronic post-op NOFs, which can also look like intermediate uveitis. So again, if you don't see adequate response, the best thing will be to go for a vitreous tap or biopsy and subject it to cytology as well as microbiology evaluation.
Something I find sometimes missed is peripheral in acute retinal necrosis. They present with severe vitreous haze, and without a good peripheral examination, you will miss the tongue-shaped lesions, and then the diagnosis completely changes from intermediate uveitis to ARM.
Thank you, ma'am. Thank you, Vandana. Now the next talk is workup of non-infectious posterior uveitis. Dr. Reesha is a uvea and retina consultant at Little Flower Hospital. Over you to Reesha.
Okay, good evening. After anterior and intermediate uveitis, we are going more posteriorly. Next is approach to autoimmune and uveitis. Okay, most of the time after several OP visits and several investigations, most of the investigations, costly investigations, our patients ask this question, doctor, what is the cause of my uveitis? And answer in our mind will be, don't ask me, no matter what causes it, I'll treat with steroids. But is it so? Why it is important to identify the etiology of uveitis? Because infection remains a common cause of uveitis and prompt diagnosis is very critical so that appropriate antibiotic therapy can be started on time. Considering an immune etiology and starting immunosuppressive therapy can exacerbate an underlying infection that can lead to blindness and rarely even death. So all uveitis workup will start with a good history taking. A complete history is crucial to the diagnosis and management. Onset and progression of symptoms, course of treatment should be, details should be received. Past ocular history includes recurrent attacks of uveitis and previous response to treatment. Apart from the review of systems, social history, pets, dietary history, sexual history, and drug history should be obtained in detail. For example, this patient presented with an endophthalmitis-like picture, a severe fibrinous reaction, hypopyon, but he gave a history of recurrent episodes prior in either eye with morning neck stiffness and low backache. So the diagnosis is very easy. He was treated with the intensive topical steroids with cycloplegic agents, and this was the picture after treatment. That was a case of HLA-B27 associated uveitis. Next comes physical examination. A patient with pan-uveitis, bilateral with hypopyon and vasculitis. On examination, patient had oral ulcers, like aphthous ulcers like this. So the diagnosis is again easy. And he also had genital ulcers and GI symptoms and arthritis. So the diagnosis here is Behçet's. Lab findings include raised ESR, CRP, and HLA-B5 or 51 may be elevated. Your rheumatology friend may help you in further managing this patient. Next comes another pan-uveitis with exudative RD and disc edema. Patient had alopecia and vitiligo. Here the diagnosis is VKH syndrome. Another young lady presented with occlusive vasculitis. She had malar rash-like picture. So that was an occlusive vasculitis of SLE retinopathy. Next comes an ocular examination. A meticulous slit lamp or indirect examination is a must for a uveitis workup, and that should be done every visit thoroughly. For example, this patient, it's very clear that it's a granulomatous anterior uveitis. Fundus shows pars plana exudates and choroidal granulomas. So that was a case of sarcoidosis. Patient had raised ACE and HRCT showed hilar lymphadenopathy. Examination of other eye is also very important because it's a case of sympathetic ophthalmia. The presenting eye had a bilateral granulomatous pan-uveitis, but other eye shows evidence of old trauma. So the traumatized eye is called exciting eye and non-injured eye is called sympathizing eye. Next comes to vasculitis. So, the common type of vasculitis is eels, including vasculitis including veins mainly, known as periphlebitis. It can be autoimmune etiology or it can be hypersensitivity reaction to tubercular protein. Next is serpiginous choroiditis. As the term describes, it has a peculiar pattern starting from perijuxtapapillary choroid and amoeboid extension, mainly extending from peripapillary area. A slow progression is noted most of the time, associated with minimum vitritis. And always exclude infectious cause. Sometimes history may mislead you. For example, this patient was a non-case of vaginous granulomatosis on chronic immunosuppression, but fundus shows retinitis patches and on investigation came to be CMV positive in PCR examination. So that was a case of CMV retinitis due to immunosuppression. And as mentioned earlier, peripheral fundus examination is very important so that we won't miss an underlying infectious etiology. And do not miss an active inflammation. Here comes the role of ancillary investigations like FFA in VKH. Also EDI OCT, it's a non-invasive modality of investigation which gives an idea about the activity of the disease following treatment. And fundus autofluorescence helps in detecting early recurrence of a serpiginous choroidopathy. FFA gives some clues regarding the extent of the disease, like in Bassett. FFA gives typical fern pattern, so the diagnosis is easy here. And always do not forget about masquerades by obtaining biopsy. Here it was a choroiditis mimicking picture, not responding well with steroids, and later biopsy was proven as intraocular lymphoma. And if indicated, do not hesitate to use steroid sparing agents. Even though the mainstay of therapy remains still corticosteroids, but after a short course of corticosteroids to control acute severe inflammation, treatment should be started with long-term immunosuppressants. Primary immunosuppression is indicated in certain conditions like Bassett's, serpiginous, sympathetic, birdshot, and VKH. Consider sustained release steroids like Ozurdex in conditions like chronic CME in pars planitis. And also think about non-uveitic conditions. This was a choroiditis mimicking picture, but later turned to be multifocal CSR. So investigations helps in some special conditions. And what to do after all investigations, still not getting a diagnosis? Discuss with your friends. It may help you in getting more ideas. So the 10 commandments are proper history taking, physical examination, ocular examination, exclude infectious cause, do not miss active inflammation, do not forget about masquerades by obtaining a biopsy. If indicated, do not hesitate to use steroid sparing agents, consider sustained release steroids, think about non-uveitic conditions, and last, discuss with your friends. Thank you.
Thank you, Reesha. Any doubts from the madam?
I think we will go ahead with the next talk and then we'll have a discussion.
Okay. I welcome Dr. Anabi Shahi to discuss diagnosing infectious posterior uveitis. Dr. Anabi is a uvea consultant at Tony's Eye Hospital, Alua.
Good evening, everyone. In the next few minutes, I will be talking about the diagnosis of infectious posterior uveitis. There are many causes for infectious uveitis, but I will be dealing with only the common causes like tuberculosis, toxo, syphilis, and herpetic group of viruses. How will you approach posterior uveitis step by step? Clinically, phenotype recognition is first and foremost. Is it retinitis, choroiditis, retinochoroiditis, or chorioretinitis? Is it associated with optic nerve head involvement or vessel wall involvement? The laterality of the lesion. Then is it focal or diffuse? Is it associated with anterior segment or vitreous inflammation? And is there any associated systemic involvement? Investigation-wise, serology, it is important only in ocular syphilis, but in ocular toxoplasmosis, negative IgG rules out toxo. Then customized multimodal imaging, radiological investigations wherever necessary, such as contrast-enhanced CT chest or USG abdomen, to rule out mediastinal and mesenteric lymph node enlargement. Then PCR of ocular fluids and vitreous biopsy wherever necessary, like in atypical cases and whenever you have a diagnostic dilemma. A quick look at the difference between retinitis and choroiditis. Retinitis, as we all know, it is superficial lesion, hence it has got ill-defined borders and it will obscure the blood vessels, whereas choroiditis is well-defined, has got well-defined borders since it is a deeper lesion and you can see the vessels over the lesion. To generalize, retinitis is mostly infectious and choroiditis is mostly non-infectious. The focal causes of retinitis are commonly toxoplasma retinitis, whereas diffuse retinitis is caused by viruses and syphilis. Let's discuss about ocular toxoplasmosis. It has got different phases. The common one is, the typical one is a necrotizing retinitis close to, adjacent to a scar. This is a fundus picture of a 11-year-old female who came to us with defective vision, and you can see the necrotizing retinitis adjacent to the scar. Here the IOP is raised. In toxoplasma, sometimes the IOP will be raised and it may be associated with pigmented KPs also. Serology is not at all important. The diagnosis is mainly clinical. Then there are certain OCT biomarkers for toxoplasma. Hyperreflective oval deposits on the inner retinal surface, hyperreflective round-shaped deposits along the posterior hyaloid, often with mirror-shaped deposits on the retinal surface. Then there will be retrohyaloid hyperreflective dots. Coming to the choroid, hyporeflectivity of the choroid beneath the necrotic retinal focus and choroidal architecture disruption. So the diagnosis for ocular toxo is mainly clinical. This is a fundus picture of a 11-year-old female. It shows bilateral punched out macular scar. It is suggestive of congenital toxoplasmosis. In such cases, the intrauterine infection might have occurred during the 3rd trimester of pregnancy. This 15-year-old came to us with defective vision and floaters. She had 1+ AC cells, there was vitritis, and fundus showed necrotizing retinitis with vasculitis. Vitritis in toxo is often described as headlight in fog, but it is rare and it is not pathognomonic of ocular toxo. Vasculitis can be of 3 types in toxo. One is chirales vasculitis, it is involvement of the arteries and it is suggestive of just infection. It is seen in some other conditions also. Then there are skip lesions or confluent lesions. These confluent lesions can lead on to inflammatory vascular occlusions. Next is juxtapapillary retinochoroiditis. This 50-year-old male came to us with defective vision in the left eye. His best corrected visual acuity was 612 N12 and fundus showed juxtapapillary retinitis with vitritis. At the time of presentation, his OCT showed full thickness retinitis with a small neurosensory detachment. He was treated with anti-toxoplasma drugs and also systemic steroids and he resolved fully. There was a small glial tissue on the disc extending onto the retina. His vision came back to 6/6. So juxtapapillary retinochoroiditis causes central visual loss. It can cause visual field defects. It can heal without scarring and neuroimaging is indicated to rule out intracranial spread. Toxoplasma in immunocompromised is different from all other cases. It can be multifocal, diffuse, bilateral, and associated with papillitis. It resembles necrotizing herpetic retinitis. And in cases of recalcitrant ARN, you should think of toxo as a cause. It occurs in HIV positive patients, elderly patients, and young immunocompromised patients. In a country like India where tuberculosis is endemic, you should think of ocular tuberculosis also when you are seeing uveitis. There are certain features predictive of tuberculosis, that is broad-based posterior synechiae, subvascular scars, and occlusive vasculitis. The various manifestations of TB uveitis are, first and foremost is TB posterior uveitis. It can be in the form of TB choroiditis, which can take the form of serpiginous-like choroiditis, multifocal choroiditis, focal choroiditis, and tuberculoma. TB vasculitis can be, it is periphlebitis and it is occlusive in nature. Granulomatous anterior uveitis with mutton fat KPs and iris nodules, TB intermediate uveitis, and TB pan uveitis. Investigations to be done are Manto test, quantiferon TB gold test, contrast enhanced CT test, EBUS bronchoscopy, CT abdomen and USG abdomen to rule out mesenteric lymph node enlargement, and PCR of ocular fluids in cases of doubt. This is a story of a 56-year-old female. She came to us with defective vision left eye of 1 month duration. She had a best corrected visual acuity of 618 N10. There was vitritis and you can see a diffuse choroidal lesion with exudative RD. OCT at the time of presentation showed choroidal elevation associated with SRF, and you can see that contact sign. That is the point of adhesion between RPE choriocapillaris layer and sensory retina. Manto was severely positive. She was treated with ATT for 9 months and she recovered fully, leaving only a small subvascular scar. This young male came to us with defective vision left eye of 1 week duration. He had a best corrected visual acuity of 660 N36. At the time of presentation itself, he had vitritis and multifocal serpiginous lesions along the inferior arcade encroaching the fovea. In serpiginous-like choroiditis, fundus autofluorescence is very important. You can see hyper-autofluorescent edge which indicates activity. In this patient also, Manto and quantiferon was positive, and he was treated with ATT and systemic steroids. In such cases, if you treat the patient alone, ATT alone, it can lead on to paradoxical worsening. So you combine with systemic steroids. It is an immunological mechanism, and if you start with systemic steroids alone, it can lead on to recurrences. He was treated with ATT and he recovered. Another presentation of TB is TB vasculitis. This young man came with defective vision of 2 weeks duration. He had periphlebitis, and if you look closely, you can see subvascular choroiditis lesion. Manto was positive. FFA shows lots of CNP areas. He was again started on ATT and systemic steroids. Next major class of infectious uveitis is viral retinitis. The triad is retinitis, pigmented KPs, and raised IOP. Causative agents belong mainly to the herpetic group of viruses like HSV1, 2, VZV, and CMV. First pattern is acute retinal necrosis. Here there is a triad of vitritis, diffuse retinitis, arterial involvement in an immunocompetent patient. The diagnostic criteria includes retinal necrosis in the peripheral retina, circumferential spread, occlusive vasculopathy, inflammatory reaction both in the vitreous and the anterior chamber. Pattern 2 is progressive outer retinal necrosis. It occurs in immunocompromised patient. The lesions are confluent, no vascular inflammation, none or minimal intraocular inflammation. It has got a cracked mud appearance. CMV retinitis again occurs in the immunocompromised patients. It is vasocentric retinitis with hemorrhages such as CMV. And 3 different patterns are there: Pisa-Pi appearance, prostaglandinitis, and the granular pattern. Severe immunosuppressed patients develop CMV like HIV, post-transplant patients, patients on biologics, and patients who have malignant disease. This 47-year-old male came to us with defective vision right more than left. At the time of presentation, he had retinitis with hemorrhages. He was found to be HIV positive and he was lost to follow-up. 10 days later, he came back with retinal detachment and his vision dropped to hand movements. Ocular syphilis, the great mimicker. Eye involvement occurs in secondary and tertiary syphilis. Posterior uveitis is the most typical presentation. Retinochoroiditis is the commonest presenting like a macular placoid lesion. Serological evaluation is important in ocular syphilis. Screening tests with VDRL and RPR and diagnostic test is with either FTABS or TPHA. The various presentations are acute syphilitic posterior placoid chorioretinitis, retinal precipitates, miliary retinal lesions. This 42-year-old male came to us with defective vision of 1 week duration. Fundus showed mild vitritis, multifocal choroiditis with vasculitis. Manto was negative. His VDRL and TPHA were positive. He was sent to the infectious disease department, but he never came back for review. Another entity is post-fever retinitis. It is an infectious or para-infectious uveitic entity. History of fever with skin rash or joint pain. Ocular manifestation usually starts days or 2 weeks after the onset of illness. It is mainly a retinitis with hemorrhages. Common causes are dengue, chikungunya, typhoid, rickettsia, Zika, and Ebola virus. This one is rare, toxocara, affects adults and children, mostly unilateral, peripheral granuloma, postal pole granuloma or chronic endophthalmitis, atypical papillitis, diffuse choroiditis. Take-home message, infectious should be differentiated from non-infectious so that it can be treated early with antimicrobials. Proper and timely referral to infectious disease specialist is mandatory in these cases. All cases of anterior uveitis, as Natasha said, should be dilated and periphery examined so that the peripheral retinitis is not missed, and ARN presents with anterior or intermediate uveitis and you might miss the peripheral retinitis. At each follow-up visit also, dilated retinal examination should be done and you should look for any new lesions. Thank you.
Good afternoon to all. Thank you, Dr. Reesha, for having me here, and thank you, audience, for bearing with this heat and staying with us through this session. So we will talk about uveitis in a child in this session. Childhood uveitis is not very common. Its incidence is only about 3 in 1 lakh in 0 to 4 years and 6 in 1 lakh in 10 to 14 years. The most common cause is idiopathic, though you can have chronic anterior uveitis, and in 8 to 16 years you can have intermediate uveitis as the commonest presentation. The common types of uveitis by age is JIA in 0 to 6 years, idiopathic in 7 to 12 years, B27 associated uveitis in the older age group. We use the same classification as in the adults, IUSG and SUN classification, based on an anterior, intermediate, posterior, and pan uveitis anatomically, acute, chronic, recurrent, granulomatous, and non-granulomatous. They have the same features, so we will talk about how they can present first, and then we'll go into specific pediatric uveitic entities. So you can have the keratic precipitates, the festooned pupil, posterior subcapsular cataract, pigments on the anterior lens capsule, and peculiarly in children, because they present very late, we have this finding in the cornea called the band-shaped keratopathy. Causes of intermediate uveitis in children include JIA, juvenile spondyloarthropathies. There's a long list, so I will not go into that. Intermediate uveitis can be idiopathic as in pars planitis or secondary to sarcoids, Behçet's, Lyme disease, and multiple sclerosis as well. Posterior uveitis, again infectious, non-infectious, the whole gamut has already been covered. Toxoplasma can present in children just as it can be in the adults, and TB as well, TB granulomas, TB abscess. One of my previous speakers touched upon this. So this is one case of 8-year-old boy, decreased vision in the right eye since 2 months, no history of redness, pain, joint pains, or any other systemic symptoms. Visual acuity was only 2/60 with an early band-shaped keratopathy, festooned pupil, and a cataractous lens, and we could not see the fundus. So B scan showed that there is no retinal detachment or choroidal thickening or tumor, and he was sent to the immunologist to rule out an infective focus. Basic infective workup all came up negative, so we started him on immunosuppression, and he underwent cataract surgery. After cataract surgery, we found this. In the periphery, there was a granuloma-like lesion. And a clinical diagnosis of toxocara granuloma was made, and the patient was put on albendazole. And post-operatively, visual acuity was good, but once the steroids were stopped, the patient then had 2/60 in the right eye with a severe flare-up of inflammation as well as a retinal detachment. And so we went in and did the surgery, and a small biopsy of the granuloma was taken, and we actually did get the organism from the biopsy. They can also present with vasculitis in the fundus, arterial vasculitis, periphlebitis, combined vasculitis, and in children we should also be aware that some of the tumors can present with uveitis, retinoblastoma. Sometimes retinitis pigmentosa can be mistaken because they will have pigment dispersion in the anterior vitreous, chronic retinal detachments, leukemia, lymphomas, juvenile xanthogranulomas. Let's go into specific entities. Juvenile idiopathic arthritis is the most common systemic association of anterior uveitis in children. The risk factors for ocular involvement are females, oligoarticular arthritis, young age, ANA positivity, and RF negativity. It's usually bilateral and usually non-granulomatous, and usually presents with the complications because they are completely asymptomatic. So they will come with band-shaped keratopathy, cataract, posterior synechia, secondary glaucoma, sometimes as cystoid macular edema and amblyopia. And they are completely asymptomatic. So like I said, it's a white eye and they present with complications. The first line of management is methotrexate and oral corticosteroids, and then depending on severity, MMF may be added later. Recently, adalimumab has been given, has got FDA approval for use in refractory cases. The topical medications in these cases have only an adjunctive role, and if you need to give more than 3 drops in a child for more than 3 months, the child should definitely be on systemic immunosuppression. So slow tapering of the topical steroids with monitoring and screening of all GIA in children are essential. Juvenile spondyloarthropathies make up 15% of the pediatric uveitis, which include juvenile ankylosing spondylitis, Reesha's, psoriatic arthritis, ulcerative colitis, and Crohn's disease. It usually affects boys more than 8 years of age, acute recurrent uveitis that is bilateral and asymmetric, and they are positive HLA-B27, but most are RF negative. They can also present with a severe acute anterior uveitis and hypopyon formation. IBD, it is inflammatory bowel disease, Crohn's and ulcerative colitis are associated with ocular inflammation in a minority. Sarcoidosis can present in childhood, again presents with granulomatous anterior uveitis as its typical findings, and complications like band keratopathy, cataract, and glaucoma. Inflammation of the posterior segment in the form of vasculitis or multifocal choroiditis can be seen. This is periphlebitis in sarcoidosis. Okay. So we'll go on to another interesting case. A 10-month-old female baby presented with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight. The general examination showed pallor, edema over hands and feet, depigmented hair, hypopigmented scaly lesions, oral candidiasis, and this was the ophthalmic examination picture. Bilateral anterior uveitis, festooned pupil, multiple posterior synechia, and scattered lens opacities in both eyes. Investigation showed anemia, skin biopsy showed some ill-formed granulomas with Langerhans giant cells with no caseation. Liver biopsy showed granulomatous inflammation with Schaumann bodies. This is the histology of the skin and liver. Stool was positive for occult blood, and endoscopy showed granulomatous duodenitis and colitis. And the child was this NOD2 gene mutation positive, negative, which means we were suspecting Blou's syndrome or infantile sarcoid. Since the mutation came negative, our diagnosis was infantile sarcoid, and the child improved well with systemic immunosuppression and topical steroids. She underwent cataract surgery in one eye and is doing well now. So early onset childhood sarcoid can occur within the first 4 years of life. It is rare, but it appears to be different from sarcoid in older children and adolescents. And liver biopsy is an important diagnostic tool. And they usually present with this characteristic triad of rash, uveitis, and arthritis in a child younger than 4 years. And when it is autosomal dominantly inherited, it is called Blou's syndrome. And it is also same triad, but they will be mutation positive. Behçet's uveitis, pediatric Behçet's is again uveitis at the age of 16 years or younger. Mean age is late childhood, male preponderance, family history may be there, bilateral involvement, recurrent pan-uveitis with retinal vasculitis. What do we do for these non-infectious uveitis in children? So we can give topical corticosteroids, but always remember that is not the mainstay of management, and you do need to give the systemic treatment. Periocular or subtenon corticosteroid injections can be given for intermediate or posterior uveitis, especially when you have unilateral cases, or for treatment of CME. Treatment of complications forms a major part of our treatment role in these children. You have to do cataract surgery when it is required, and it always be careful because severe exudative reaction is the norm. You have to step up systemic immunosuppression 2 weeks prior, give them systemic steroid cover, slow taper of both systemic and topical, and you may need to continue topicals for more than 6 months in these children. For band-shaped keratopathy, EDTA chelation or PTK can be done. For CME, you can give either the posterior subtenon if possible, or you can use the dexamethasone implant. I will stop with this last case, 12-year-old girl, bilateral pan-uveitis with vitreous haze, complicated cataract and BSK. Vision was only hand movements when she presented to us with ciliary shutdown and hypotony. And she had to undergo cataract surgery with vitrectomy and oil. And she now maintains 6/12 in both eyes, but we cannot remove the oil because she's at risk of detachment and hypotony. So sometimes you do have to go in for vitrectomy, sometimes for diagnosis, but mostly therapeutic when you have grossly reduced visual acuity due to vitritis. And with the small gauge vitrectomy, now we have less morbidity in these children. In conclusion, pediatric uveitis is a challenging subspecialty, and it requires close cooperation with the pediatric rheumatologist and ophthalmologist to ensure accurate diagnosis and optimum treatment outcomes. Thank you. Sorry for running. This meant for a longer presentation.
Thank you, Dr. Natasha. I actually have a couple of questions for you because I find pediatric uveitis, very difficult to treat. So can you tell us, what's the role of systemic steroids? Do they have a role at all in managing non-infectious pediatric uveitis? That is the first question. And second is, very often we have to put them on biologicals. I find the pediatric population requiring biologicals more than the adult. So what's the minimum duration of,
Refractory.
of using adalimumab?
So role of systemic steroids, unless it is indicated for the joint complications, especially in JIA, so unless it's indicated from the rheumatologist side, I advise the rheumatologist to start the systemic steroid only for covering the period while the methotrexate kicks into action if the patient is treatment naive. So sometimes for a period of about 2 months and then taper to maintenance, and then usually tapered and stopped once the methotrexate has started acting. And along with that, I start the topical steroids also, and again taper over the next 3 months. And about adalimumab, yes, refractory to, we usually give methotrexate first, not acting, we add MMF to it. It is still not acting. Usually we give a period of 6 months, unless the child has very poor visual acuity and we are expecting, like these blouse and sometimes the pan-uveitis in Behçet's do not respond so well, and very rarely we have given it as first line also, but generally after waiting for 6 months.
Thank you, Dr. Natasha. I just want to mention a couple of points about the infectious versus non-infectious posterior uveitis. So probably that is the question, whether it's an infection or an immune-mediated disease. So any patient who is immunocompromised and developing a de novo inflammation, you should consider it as infectious. Any patient who is developing de novo inflammation after surgery or after hospitalization, it should be thought as infectious. And I think as Dr. Anabi already mentioned, most cases of retinitis is infectious. Of course, if you see hypopyon again, you will consider it as infectious. Anything which, doesn't quite fit in with, a particular pattern, again, think of infections. And last but not the least, lack of response to steroids, think of infection.
So we are winding up this session. Thank you. I thank all the speakers and all the delegates who came here. Thank you, Dr. Anabi. Thank you, Dr. Rajeshri, Dr. Natasha, and Dr. Anuradha Madam for moderating the session. Thank you.